So this is the 5th module of the Make Cancer History course, and it is all about chemotherapy and molecular targeted therapy. So chemotherapy is really like the backbone of cancer treatment, unfortunately. I think most people, or most cancer patients, know that chemotherapy came from chemical weapons. So really mustard gas in World War I. So from your history lessons, maybe you remember mustard gas is it's got like a high vapor pressure. So that means it like hangs around, I think like around kind of waist height or chest height, and attacks the body, particularly the lungs. And it was observed in World War I that soldiers who had kind of lesions and wounds, some of those kind of shrunk a bit when exposed to mustard gas. And particularly, it was also observed that their white blood cell counts were low. So there was kind of a hint that this might be good for treating the blood cancers, which are cancers of the white blood cells, so the leukemias. And then this was sort of came up again in World War II, rather interestingly. Although chemical weapons were banned after World War I, the US had quite a stock of mustard gas, and there was an accident on a warship, US warship in Italy, and a bunch of mustard gas got out, and yeah, a lot of I guess the US Navy were exposed to this mustard gas, and again you saw low white blood cell counts, and from this was developed chemotherapy. So I mean the word chemotherapy just means treating cancer with chemicals essentially, but when people talk about chemotherapy, what we generally mean is like essentially the use of poisons that interrupt the like cell division or like cell division and growth cycle, really, that cycle that we probably all learned about in school, where you know I can't remember my basic science, but like the nucleus where the DNA is gets a bit bigger and divides, and the cell divides, and where you had one cell you now have 2, and then 4 and 8 and 16, keeps going with those powers of 2. So with mustard gas there was a problem. Of course, it's a deadly poison, and yeah, that was really no good as a medicine, but it was possible to like make a modified version, and yeah, that was like the first chemo. So we really think about chemotherapy as drugs that damage the cell growth cycle, I guess. And we often think at like one of the almost definitions of cancer is this idea of unregulated cell division. Obviously, when we're growing as kids, cells are dividing a lot. So that means, yeah, there are big issues with using chemotherapy for children who are growing. But as adults, we're not growing generally, but we do have a lot of cells dividing. Our skin is getting like replenished all the time. Lining of our like GI tract, so stomach lining and intestines or whatever. So that's why chemotherapy causes us all those problems with digestion. So all that wonderful constipation and diarrhea that we get from chemo, that's why that happens. Yeah, skin and of course hair follicles, that's why our hair falls out. I didn't have a lot of hair anyway, so that was okay. But yeah, it's obviously a classic side effect of chemo. Also, things like the nail beds, you know, around where your toenails and fingernails are growing. That can be a really really tough side effect to deal with. At points during my treatments, it was really difficult to walk because of damage of those drugs attacking around my toenails. Very, very unpleasant. Chemotherapy generally does not cure cancer. It's generally not a curative treatment, at least superficially. So although chemo is really used in like 3 ways, so for early stage cancer, often single chemo drug is used, and I guess that could be curative, although presumably what's happening is the chemo is killing a lot of the cancer and the immune system is recognizing these dying cancer cells and then taking care of the rest. And then in late stage cancer, chemo is usually used as a combination, possibly with other chemos, and of course now with molecular targeted therapy as well, which I'll talk about later. And that's called adjunct chemotherapy. So, adjunct chemotherapy is the third way, which is used particularly after surgery. So chemo seems to work better when there's not so much tumor burden, so just physically not so much cancer in the body. So used after surgery to hopefully prevent the cancer kind of coming back. Although, again, we must be a bit careful because it's not really like going away and coming back. It's more like there are probably cancer stem cells hanging around and it recurs. And chemo dosage is generally based on the surface area of your skin, because that is a good proxy of how much blood is in the body. So when you see like chemo dosing, it will be a certain number of like milliliters or milligrams per square meter of patient skin. It's a little bit weird, but that's how they do it. And chemo is often taken as an IV drip, so intravenous drip, and often if you're having a lot of chemo like I was, you'll get a chemo port. So I had a chemo port, it's been removed now. Not sure if I can show the scar, but somewhere, maybe you see probably around here, was where my chemo port was. Sometimes called a PICC line. There are various like brands, various kinds, and essentially it's a chunk of plastic that's put under the skin with a tube leading from it towards the heart, and that makes it kind of convenient for putting needles in, particularly if, like me, you have narrow blood vessels. So about half of all people have quite narrow blood vessels, so it can be quite difficult to put in an IV drip. But also a chemo port is useful because with many chemo drugs, the side effects at the point of where it's put in are less with a chemo port. So the chemo that I did originally, Folfox, so that's a combination chemo of 5-FU with oxaliplatin. That's one where if you don't have a chemo port and it's just put like directly in your arm, there's a bit more risk of like trouble around the injection site. And third reason for chemo port is that some chemotherapies are given as a very slow infusion, like a few milliliters an hour. So for people with colorectal cancer, many of us are familiar with the slow infusion for like 46 hours of 5-FU. So you have like a little device with it, essentially with a balloon of chemotherapy drug in, and the atmospheric pressure pushes on that balloon, and the balloon slowly deflates, dripping the chemo into your body. So for that, you really would want a chemo port. Chemo can also be taken orally, and in that case, I think it's not usually got the like chemo drugs in the medicine, but it's got what's called a prodrug. So prodrug is a drug that turns into the final drug in your liver. So Xeloda would be a famous example of that, which contains prodrugs of 5-FU. So you take that Xeloda tablets and they turn into chemotherapy in your liver. And that has advantages and disadvantages. It's nice just to take some tablets instead of going to hospital for a day of drips and then doing your slow infusion. But what happens when you take the tablets is that you get like a peak of chemo drug in your body and then a sharp kind of decrease. So that means it can't be used in certain combinations, certain combo treatments. So specifically with Xeloda, it doesn't work well with Erbitux, which is a molecular targeted therapy often used with 5-FU for colorectal cancers. For that, to get a good result from Erbitux, it seems you need the slow infusion. I should say, like on the subject of drugs, one thing we need to be a bit careful of, particularly when we see reports of new drugs in the media, or if people are trying to sell us miracle cures, is that lots of things kill cancer very effectively in the lab, and it's very, very different from them being a viable cancer drug. And part of the reason for that, as I've just said, like, is that the liver is in the way, right? So when you, for example, when you take a chemo tablet that contains a prodrug, it's being metabolized in your liver, turning into the chemo drug. So there are plenty of things that will kill cancer in the lab, but when they're actually in the human body, and your body's got a lot of defenses against toxins, our liver is very, very effective at detoxifying our body. I mean, that's one of the many, many roles of the liver. So we need to be a bit skeptical, and you'll sometimes hear in the media, you know, a game-changing drug has just been developed, and in preclinical trials, you know, there was 100% success rate. And all that means is that they found something that killed cancer in mice in the lab, of which there are thousands and thousands of things. Very few of those become viable drugs because they might not work in humans, or they may have side effects that can't be tolerated, or they may have kind of unforeseen consequences. You know, they may do sort of damage to you that can't heal. So please be very skeptical when you see these media reports of like new game-changing cancer drug. Basically, for research scientists, unless they say something is revolutionary and game-changing, the media just don't want to know. You don't even get a mention. The media are not interested in the reality of slow drug discovery over many years. And it's interesting that chemo came from chemical weapons, and the chemo worked, and then later it was found why it works. So in the case of those mustard gas derived ones, the chemo it makes links across the DNA, so the DNA can't divide, and the DNA can't do its job of making RNA and like building proteins and doing, you know, expressing itself, as the scientists say. So the drug was discovered, it worked, and the mechanism was discovered later. So if you think like after World War II, like 1950s, that's when DNA was discovered, like the structure. 1953, double helix was discovered. So that's kind of people could work out this is how it's working. Now, of course, drug discovery is moving a lot in the other direction of finding mechanisms and then making drugs that work with those. So particularly with the molecular targeted drugs, where there are targets on the cancer cell and then drugs that can be made to work with those. One other way that chemo is sometimes taken for like skin cancer is a chemo cream. So I mentioned the boring old drug 5-FU. That is available as a cream as well for skin cancer. And one way that chemotherapy can be made more effective is by using something called hypothermia therapy. So heating up tumors or areas of the body. I think for some cancer patients, we've heard of this thing called HIPEC, which is a heated chemotherapy procedure for some gynecological cancers that have spread to the abdominal membrane, colorectal cancer that spread to the abdominal membrane, asbestosis, which is a lung cancer you get from exposure to asbestos. That was how HIPEC was first developed. But there are other forms of hypothermia therapy as well, and one that's used quite a lot in Japan and also in Germany is a regional hypothermia therapy, where you lie in a machine for about like 40 minutes and a region of your body is heated up. So the one I did, the machine heats like a 30 centimeter section of your body. So in my case, I had the machine targeted at my liver and the abdominal membrane. And it heats up that part of your body to kind of fever range of temperatures. So that's like 41 degrees, that kind of temperature. Maintained that temperature for half an hour, 40 minutes, something like that. And one of the consequences of that is that you get more blood flow in there. So, you know, when your hot blood rushes to the hot places so you can lose heat that way. Of course, the opposite happens when you're cold. The blood goes into your core, and you know your skin kind of turns pale, particularly fingertips, and you get the cold toes. So hypothermia therapy, heating up the tumors to increase the blood flow, so you get more chemo in. That was particularly important for me because the cancer had spread to the abdominal membrane, and not much chemo gets into the abdominal membrane because there's the membrane. And the tumors, they also have a poor blood supply. So heating them up is a good way to make chemo more effective. The effect is probably not massive, but it's a safe, cheap treatment if you can access it. And yeah, no side effects really. It's very uncomfortable. But when they turn the machine off, yeah, the heating stops immediately and you're fine. Kind of uncomfortable for the 40 minutes lying there. Although, yeah, I did eventually get so used to it that I could read a book while doing it. So kind of sweating profusely as my tumors were heated up. But, you know, if it makes a few % difference, it's potentially worthwhile. Which brings me very neatly on to something I hadn't considered, which is that one use of chemotherapy can be to make other treatments possible. So particularly shrinking tumors so that you can do surgery, for example, or if you have several tumors, say you have 5 tumors and 2 are kind of small, maybe chemotherapy could shrink them enough so that the 2 small tumors almost disappeared, and then you can have radiotherapy for the other 3. Whereas without doing chemotherapy, a radiotherapist may say, well, I can't treat 5 tumors, it'll be too much radiation for you, so you get no radiotherapy. So sometimes chemotherapy can be a good way to get to another treatment. It can make surgery possible. So think of a liver, you know, if you have lots of liver tumors, and maybe they're spread throughout the liver, so it's kind of too dangerous to do one-step liver surgery, but chemo might be enough to get rid of some of the tumors or shrink them enough that you could then do your liver surgery. There are lots of different mechanisms for chemo. There are like there are like 5 kinds of chemos that, yeah, they work in different ways. Some of them like cause the DNA to fuse together, like I mentioned, the kind of the mustard gas derived ones. Some like suppress enzymes that are used to prevent mutations happening, so then the cells get too mutated and die. And yeah, various mechanisms, but from a patient's point of view, yeah, chemo is unpleasant and is something that we tend to do a lot as cancer patients. Lots and lots of different combinations of chemos at the moment, 70 plus combinations, I think. Typically, chemotherapy does seem to work better as combination treatments, particularly in these ones with molecular targeted treatment as well. If you are a cancer patient yourself and you've done chemo, then you're very familiar with the side effects of fatigue and skin trouble and hair trouble and nerve damage. For me, the toughest to deal with, I think, was the nerve damage. That's like quite scary. So you get damage in the peripheral nerves, so there's like those long nerves in your arms and legs. You have to like dropping stuff, which is kind of scary, and doesn't seem to be much you can really do. If you're suffering a lot with that, something worth looking into though is called scrambler therapy. This has been done as trials in the US. I think maybe Cleveland Clinic was one of them. So scrambler therapy is like using electrostimulation. It's a bit like those TNES machines that some people use if they have paralysis problems or whatever. So in the case of scrambler therapy, it causes a lot of nervous stimulation, and for some reason that seems to reverse the damage pretty effectively. So that's one thing you can look into. For skin trouble, the really important thing seems to be early intervention. So when you're going to start chemo, typically the nurses and maybe the doctors as well will tell you, start your skin treatment before you do the chemo. And it's very, very good advice. So really doing the moisturizing to strengthen up the skin barrier. For a lot of chemos and some electrotargeted therapies, you'll be given like a 3-step skincare thing, which will be a moisturizer and some kind of antibiotics. So that might be like a skin cream one or tablets, and then steroid as well to kind of calm down the painful skin rashes. For hair, in the UK, for some reason, a lot of emphasis is put on these cold caps. So the idea is like the opposite of what I explained about hypothermia. So you have this like cold cap that goes on and stops the chemo getting into the hair follicles, and seems to work a bit. I don't know why it's pushed so much in the UK, but whenever I look into hair loss, particularly for those gynecological cancers, in the UK, they seem to emphasize that cap a lot. Fatigue is a really, really serious issue because it has such an impact on your daily life. The only thing that I personally found that could help with the fatigue was gentle exercise, and I certainly did not want to do exercise of any kind when I was on chemo. But that's all I found. So when you go to hospital to get your chemo, it will be like a cocktail with usually various chemos, molecular-targeted therapy, um, some anti-vomit drug. It's often like an anti-allergy drug, so that's kind of for safety to stop you having an allergic reaction. And then also steroids. Steroids are obviously kind of extreme drugs, as we all know. And I found that, like, for the first 2 or 2.5, sometimes 3 days after chemo, I had a lot of energy because of the steroids, but it caused a lot of problems because one thing is some of those steroids are like boost your appetite, so you feel hungry, but you don't want to eat because you're feeling sick. The steroids tend to interfere a lot with the sleep. So I was given steroids as part of the drip, and then I was given steroid to take. I think I was given Decadron, dexamethasone. So dexamethasone, also called Decadron, is a steroid that is very flexible as an oral steroid because it typically comes in very small tablets, so you can adjust it very well. I really struggled with it because it made me too hungry, stopped me sleeping, also caused me to sneeze a lot, like for hours at a time, which just after surgery was really unpleasant because I had pains from the stitches. So yeah, good luck with the steroids. I didn't find them particularly useful. Gentle exercise was the only thing that worked. A big thing for controlling side effects is dose reduction and like having the chemo less frequently. Problem with that is if you're having a chemotherapy with molecular targeted therapy, some of those don't work at reduced dose. And also, I just can't find any serious research about dose reduction and about the kind of chemo holiday. So when your oncologist says, skip this cycle or put more time between the cycles, I just couldn't find really good, convincing research of how safe it is. Sometimes we have to miss chemo because white blood cell count is too low, or we've got an infection or whatever. Because chemo wipes out our white blood cells, it makes us more open to infection, which is a problem. And then there's another side effect that all chemo patients are familiar with that we don't really get any help with at all, and that's called chemo brain. And chemo brain is this kind of mental fog that makes it hard to think and do stuff. I found it very hard to kind of take any action. I'd be sat on a chair or lying in bed, like knowing I had to do something and wanting to do something, and then the time would just be passing and I couldn't do it. This is one of those examples of something that's very complex, and therefore the medical world just doesn't acknowledge it. So you may be told, oh, that's just fatigue. You may be told there's no clinical evidence for chemo brain. But yeah, I've talked to enough patients over the past 6 years and I've experienced enough chemo brain myself to know it's absolutely real. Now, yes, it may be that there are a whole bunch of mechanisms there, and maybe a really big one is just fatigue. And I should say that chemotherapy-induced fatigue is very different from exercise-induced fatigue. So exercise-induced fatigue is when you're tired from exertion and then you rest and then you're okay. With chemotherapy fatigue, it seems that when you rest, you're not okay afterwards. So resting doesn't seem to help. The same for people that have those chronic fatigue syndrome like ME. So that's kind of a bit about chemo. So very briefly, I'll talk about molecular targeted therapies, which are often confused with chemo. And very crudely, there's kind of two types or two families. There's the monoclonal antibodies that basically attack the cell from the outside or label the cell and it's attacked by the body. And then there's those, the small molecule inhibitors that go into the cells and do damage in the cell, stop the cancer cells doing what cancer cells want to do, like dividing and that kind of thing. And often I think people confuse monoclonal antibodies with immunotherapy or immunotherapies. And in the UK, oncologists often confuse these, and they say, oh, you can do this immunotherapy. And people excitedly write in the Facebook groups or whatever, they're starting an immunotherapy drug, thinking it's going to have the amazing results of what they've read about in the media when you hear about CAR T cell therapy or something. And then, yeah, someone like me has to kind of gently break it to them that, yeah, they're just getting standard molecular targeted treatment that's, yeah, the rest of the world's been using for decades. So a really important thing to understand about monoclonal antibodies is that there are three kinds. So there are ones that come from animals, and I think they're all, I'm pretty sure they're all mouse derived. Maybe a couple are pig derived. And then there's partially humanized ones, and then there's fully humanized ones. So just the example I'm most familiar with, there are these molecular targeted therapies called Vectibix and Erbitux. And Vectibix is fully human. If you're somewhere like the UK, you'll probably know that as panitumumab. So Vectibix is the commercial name, panitumumab is the generic name. And Erbitux, the generic name for that is cetuximab. So if something ends mab, it's going to be a monoclonal antibody, hence mab. And cetuximab is animal derived. And you'd think that you'd want fully humanized ones. And pharmaceutical companies may say, oh, fully humanized is better because maybe less chance of an allergic reaction, maybe less severe side effects. But particularly if you're having immunotherapy, it can be better to have the partially humanized one or the animal ones. So in the case of Erbitux against Vectibix, for example, Erbitux seems to be able to label the cancer cells as cancer cells because it's an animal-derived drug. Your immune system kind of recognizes that and thinks this is something a bit odd, I'll attack it. So it can be a way, particularly if you're having immunotherapy, it can help the immunotherapy work a bit better. I should say at this point, I'm not a doctor, I'm not giving any medical advice. I do, however, have some very strong opinions on cancer treatments. And I'll say something that oncologists probably won't say, which is that molecular targeted therapies, if they're narrow, like a specific target, quite a narrow target, they seem to work for about 12 months. And if they're broad, like if they're multi-targets, you may have heard of like multi-kinase inhibitors, which is a type of molecular targeted therapy that obviously attacks kinase. Kinase is a type of enzyme. If you remember, enzymes are biological catalysts. So if you have something like that, a multi-target one, it's harder to get disease treatment resistance, so you potentially can get a good response for a lot longer, but because it's multi-target, the side effects are much worse because far more healthy cells are going to be hit. So this is kind of like the big problem with molecular targeted therapy. So the drug companies are really pushing them, particularly in conjunction with what's called liquid biopsy or sometimes next generation sequencing. So this idea of like you can read the genetics of the cancer, so you can check out the genome of the cancer and find the targets and match it up to the drugs. And what the drug companies don't tell you is that the business implications of that are very good, because if the patient gets a good response, that response may last 6, 8, 12 months or whatever, and then the cancer is resistant to that targeted drug. So you then do another genome test, and maybe there are new mutations have developed in the cancer, and then you can do another molecular targeted therapy. So from a business point of view, that's fantastic, because you can use these very, very expensive drugs for maybe 12 months at a time and switch the patient, which, I guess you could say it's great because you get to live, hopefully. But that's treating cancer as a chronic disease, or like a series of chronic disease, I guess. So I don't think that's a winning strategy for dealing with cancer. Some molecular targeted therapies only work for people with certain mutations. So, for example, the drugs I mentioned, Erbitux and Vectibix, they work for mutations where the cancer cells are producing too much of this thing called epidermal growth factor receptor. Epidermal reminds us that it's something to do with the skin, and this of course means that those two drugs have horrific skin side effects. I haven't had Erbitux now for a couple of years, but there's permanent damage done all over my face, which you can see, where I had a really, really terrible skin rash for a couple of years while I was on those treatments, and all the blood vessels in my face got destroyed. So yeah, now I look like someone who's been drinking whiskey since a young age, which certainly not me. So yeah, other molecular targeted drugs don't rely on mutations. So a good example of that would be Avastin. The generic name for that is bevacizumab. And Avastin is a angiogenesis inhibitor, which means it prevents cells from growing new blood supplies. Every cell in your body has to be within a few cells from a blood supply. So if you think about a cancer tumor that's growing and growing and growing, it needs some blood vessels in there, needs some blood supplies. That's why when you see cancer on a scan, it's got that very characteristic kind of ragged edge. Non-cancerous tumors or like cysts are often very rounded, and the jaggedy ones are the cancer, because the cancer's kind of growing, searching for blood supply. It's kind of spreading out, growing in a jaggedy way. So Avastin stops cancer making new blood supplies. However, it also stops your healthy tissue a lot making new blood supplies, which means you do get a lot of problems with wound healing. So this is why if you're on Avastin and you're going to have surgery, you'll be told to stop the Avastin for like 4 weeks before surgery. And after the surgery, you'll be told you can't restart it for quite a few weeks as well. Now, interestingly, Avastin seems to have another mechanism as well. So even though it was invented, I think, as an angiogenesis inhibitor, it also seems to perforate cancer cells, which is why Avastin works so well with chemotherapies, because if you can imagine, the Avastin can make holes in the cancer cells, and more chemo drug can get in and damage it. In late stage cancer, so stage 4, it seems that Avastin doesn't have so much ability to stop new blood supplies forming, but it still has this ability to perforate cancer cells. So despite what your oncologist may tell you, Avastin still is very useful for stage 4 patients. It may be your oncologist is just confused because when Avastin was first trialed as a monotherapy, so that means just by itself, it was found it didn't stop cancer growing in stage 4. But actually, yeah, with other treatments, it then has that other role of perforating the cell wall. Now, Avastin has some nasty-ish side effects, so it interferes with wound healing. It causes a lot of nasal bleeding, so you kind of get used to daily nosebleeds. It can cause holes to appear in your body, which is of course incredibly serious, but that seems to be very rare. But if you have holes in your body, maybe from surgery or from some other kind of problem from a cancer treatment, then you wouldn't be able to take Avastin. It would be not available to you. Avastin is kind of expensive. There is a biosimilar drug, which means there's kind of a drug that is exactly the same as Avastin, except it's been changed enough that the drug company don't have to pay, I think Merck, who owns it. So depending on where you are, you may be able to get Avastin as a biosimilar, which can be a lot cheaper. Avastin is a very standard cancer drug in almost every country in the world, or every country with a developed health system. If you're in the UK, it's currently, I think, not standard for most cancer types, so you'd have to get it from the Cancer Drug Fund. Sometimes they change the name of the Cancer Drug Fund. I think it's changed back to the Cancer Drug Fund at the moment, but that basically means your oncologist has to fight and apply to get the drug for you, right? So the Cancer Drug Fund lets you access drugs that are not standard treatment. Yeah, I'm not a doctor. However, if you wanted to say what is a game-changing cancer medicine, Avastin would certainly be it, because it seems to help across so many different kinds of cancer, making the chemo work better. Another side effect of Avastin is you get high blood pressure. So if you already have high blood pressure, that again may be a reason why you would be told you couldn't have Avastin. There are a whole bunch of other molecular targeted treatments like MEK inhibitors, PARP inhibitors, which stop cancer repairing well. So if you're told that a drug won't work for you, it's always worth seeing if there's a trial of that drug with another molecular targeted therapy. But actually that goes not just for drugs, but for other treatments as well. So, for example, the PARP inhibitors might be good for radiotherapy, because if you can imagine, the radiotherapy is damaging the cancer cells, damaging the DNA, and then the PARP inhibitor, the PARP inhibitor, stops the cells from self-repairing. And this is a really huge area for clinical trials. So if you've been told a certain immunotherapy isn't an option for you, then you want to search online for that immunotherapy to see if there's a trial of it, maybe with another drug. So a specific example recently is there have been trials of checkpoint inhibitors, but with patients who shouldn't respond well to checkpoint inhibitors, but combining them with other drugs to try and get a response. So for example, for me, my cancer is MSI low, so microsatellite instability low. So I've been told checkpoint inhibitors shouldn't work for me, but there are trials using them with another drug. So if and when my cancer comes back, that might be something I will look into. So I've just given you an overview of the delights of chemotherapy and molecular targeted therapies, and I hope it has been useful.